Okay. Good afternoon, everyone. I have got the thumbs up here. Welcome. It's Monday. It's cardiac rehabilitation rounds. I'm Jennifer Reed. I serve as the program chair for cardiac rehabilitation at the University of Ottawa Heart Institute. Last year, we launched cardiac rehabilitation rounds, our series, with presentations every other month from September to May, with the goal of focusing on international relationships, international researchers to increase knowledge translation and strengthen collaboration in cardiovascular prevention and rehabilitation, both within and outside the University of Ottawa Heart Institute. We are particularly delighted this afternoon or this morning, depending on where you're joining us from, to honor Dr. Gerson Cipriano to this hybrid event. We have audience members in person here in the Fustinellis Auditorium, and in this hybrid event, those also online joining us from across the globe. For those in the room, any questions following the presentation must be posed using the standing microphone just over here to my right or to your left. And for those joining us virtually, please submit your questions using the Q&A feature, not the chat as per usual. We'll also be accepting live questions at the end. Use the hand up feature and you'll be asked to unmute yourself by the moderator. And use the chat feature if you're experiencing any technical difficulties. So our typical process as per usual Monday rounds. Well, as I said, we are particularly delighted to have Dr. Gerson Cipriano joining us virtually this afternoon. He is an associate professor at the University of Brasília in Brazil and is currently on sabbatical as a research scholar at the University of Miami in the US. He completed his Bachelor of Science in Physiotherapy from the University of Oeste Paulista in Brazil. Apologies, my Portuguese is not that good, so I've probably mispronounced, but please bear with me. He later obtained his MBA from the Brazilian Business School in Sao Paulo in Brazil, which I believe has informed some of his research efforts to date and that we'll learn from this afternoon. He then went on to receive his master's in health sciences and cardiology from the Federal University of Sao Paulo in Brazil, and his PhD in health sciences, cardiovascular surgery, specifically from the Federal University of Sao Paulo in Brazil. He is a cardiovascular rehabilitation and clinical exercise physiologist specialist with over 2 decades of experience in academia, clinical settings, and as a research consultant. He has demonstrated success in leading educational programs, coordinating research initiatives, and improving patient care through innovative rehabilitation programs. He's published over 100 peer-reviewed publications and 23 book chapters, has led 18 research grants, and has 14 personal awards or distinctions from across Brazil and the United States. His research interests include cardiopulmonary rehabilitation and exercise physiology, AI applications in healthcare, and systemic effects of reduced physical fitness post-COVID. Today, he'll be presenting on innovative technologies for exercise prescription and monitoring in cardiovascular rehabilitation, emphasizing how advanced technologies and AI enhance clinical outcomes through precise exercise prescription. And with that, I will turn it over to Dr. Cipriano to deliver his cardiac rehabilitation rounds. We look forward to listening. Thank you.
Thank you very much. Can you guys hear me?
Yes. We can certainly hear you, and we'll just wait for the screen to move over. There we go.
Okay. Okay, thank you very much again. So good morning or good afternoon, everyone. So I would like to start thanking Dr. Jennifer Reed for inviting me to participate to this important meeting at the Heart Institute of University of Ottawa. And I had the privilege of meeting Dr. Reed personally last year, and we began to collaborate in some scientific studies. And I'm hope it's just a beginning of a bright future ahead. So thanks again for this opportunity, and we truly appreciate this opportunity, okay? So as already presented, so my task today was try to discuss some of the exciting advancements on the field of health technology and how the recent studies or recent findings can help us to understand the cardiovascular rehabilitation field. I declare that I don't have any conflict of interest and as I read said, so we received some grant from several agents in Brazil and abroad. This is our main building at the University of Brasília, which I invite you to be there in person. So it's a very nice building, and research group, the web page from our research group. So it's just some few photos from our lab and our facilities where we treat and evaluate patients. So along these last years, and a little bit of the how we developed this program. So performing strength aerobic training, and also a lot of training sessions with the patients, as you can see here. And also, most importantly, I would say my preferred room on the building, which is the CPAT room. So where we run some tests on those patients. So you want to start asking this important question and try to answer, but what is the size of the problem we are talking about today? So unfortunately, despite of the significant advances in healthcare, especially in the cardiovascular field, the increase in life expectancy possibly correlates with a rising number of cardiovascular disease. And according to this last data from the Institute for Health Metrics and Evaluation, the age standardized daily continues to have a substantial social impact in many countries, particularly as we can see here on the Africa and Eastern Europe. However, it's still also something relevant in the North and South America. Um, we can also translate these numbers, which means that that's a daily around 3,000 will mean a reduction on 11 days on expectation of life. So that's something important to consider. Uh, the second question I would say but how does technology influence cardiovascular health? So you probably are facing a lot of changes nowadays, and it's a hot topic in several journals, including this publication on circulation at the beginning of 2023. Um, but at that time, so just after the pandemic period, so the technology was pretty much uh, thought as a very good alternative to try to increase the participation rate, which is still a problem, I mean, around the world. So they on with this publication, so they want to change the actual number from the current number from the 20% to 70%, which is a big increase. Um, if we go to the to the company or to the company perspective, we also mentioned that if we go to the immersive technology, advanced rehab wearables, rehabilitation robotics, and telehealth. So all these four items, they include or they sum up 60% of the top 10 rehabilitation technology uh, in the last report in 2023. So it's also something economically important, as we can see. I also like this review, which was a very interesting review that was wrote in 2021. We actually spoke a little bit about the relation between the advances on technology and this relation with the increase of life expectancy, as I said previously, but also the increase of the overweight and obesity and in the entire population. So that's a very paradoxical uh, infant comparison. Um, of course, that's in the same article. They also say that the technology might be on the current pathway, which the development are more related to the sedentary habit and the physical inactivity, but they can certainly be used as in a different way, a different technology, as we can see here, trying to increase motion, trying to increase motion via virtual reality or telehealth, and go in a different way and trying to get or trying to align with the United Nations Sustainable Development Goals, especially this one, which is the good health and well-being. Um, it's also important to ask, but are the cardiovascular rehabilitation programs using technology? So the last article we found on the literature will be this one that was conducted by the British Association, but they also include some data from other countries. And on this article, they show that despite the the huge improvement or the significant advance in the number of cardiac rehabilitation program using or start using technology, this number is still pretty low if we notice that it's less than 100 program use technology out of the 330 uh, rehabilitation programs assessed on this research. Um, of course, that we can also notice, as we will see in a further other article, that's after the pandemic period. So the increase seems to be increased much more. So if we spoke in terms of the what types of technology are pretty much used or considered uh, in this cardiac rehab settings, we're going to notice that actually, I mean, they consider technology using the telephone or using pre-record online video as the most prevalent technology used, email or live video conferencing, which I would say nowadays is not so technological, I would say. So we don't see many cardiac rehab using the most advanced things more related to app developing or app using or even the artificial intelligence, which is it's a hot topic nowadays. So we also had an opportunity to conduct a similar study in Brazil, so which was the largest study including 59 centers in Brazil. So we discover some pretty unique information with the study. So first, that the 59 programs in Brazil offer around 5,300 cardiovascular cardiac rehab uh, places available for patients monthly in Brazil, but only 1,800 of those patients, of these cases, were considered acute case, which means if we compare this number with the 91,000 patients hospitalized monthly in Brazil, so it will end up in a number which is lower than 2%. So, which means probably not much more than 2, or I would say 4% of the population who was hospitalized by cardiovascular disease was referred to a cardiovascular rehabilitation, which is a pretty low number. In Brazil, we also found this 5 technologies, as we can see here, as the most used technology. And if we compare, I mean, what happens during the pandemic period, we would say only the promotion material was the only item that really changed when we compare pre and post pandemic. And the second most, but it's still not significant, was the app and software implementation. During the pandemic period, I also had an opportunity to participate on this article, who tried to establish a framework or some recommendations of how does a technology or a telerehabilitation would be or need to be offered for cardiovascular patients, especially in this case with frailty. And we kind of expand the previous established core components for cardiac rehab, just uh, making attention on the health related and skill related exercise domain prescription items, as we read know and has already applied for other healthy population. So the third question I would say is but is technology helping? So if we go to the literature, I did this search this last week, and I would say on the last 12 months, we find 78 studies matching cardiac rehabilitation and also some type of technology. Uh, out of this 78 studies, we find 8 systematic review, which will be pretty much the data will try to present and answer this question if the technology is helping cardiovascular rehabilitation. So first, before we move forward, I think it's important to make some definition. For me, it's also something important to remember when we look at the articles. So, and sometimes we might experience reading different terms. So I think it's important to just go back and see what's the main difference between these terms. So when we look at digital health, so this is a term that is more used for using digital technologies for optimized cardiac rehab through data use. So that's more related to data use. The e-health, it's more related to electronic tools supporting coordination and management of cardiac rehab programs. The m-health, it's more related to mobile devices and apps for monitor and also advising patients. The telerehab is the remote delivery of cardiac rehab using telecommunication. And as well, the telehealth, it's a more comprehensive remote cardiac rehab, including both patient care and education. Okay, so from these 8 studies, so I will just present some of those or the results from those, and we can try to get an idea. I mean, uh, if technology is helping or not. So this is the most recent study who look at the difference between the combination of the mobile health combined with cardiac rehab programs uh, with the cardiac rehab alone, and they saw using this all these articles as we can see here, more than 2,000 patients included on this systematic review. That yes, so using the remote technology, they increase the quality or increase the result from the cardiac rehab alone. And this result in terms of peak VO2, for example, will be 1.02 greater than a conventional, which is already, I mean, presents some results compared to a conventional treatment. So I would say that's a big impact. Um, but there's a difference in when they compare, I mean, short-term and medium-term effects. So not so much, but it's a difference. Um, Also, as we notice, or as is something quite new, I would say, using technology. So risk of bias from these studies is still with moderate risk of bias, indicating that we have to take care and we have to look at more large database and more large study in the future just to confirm these results. Oh, that's another second study that I decided to dive in a little bit more, which tested the digital health and patients following cardiac rehab, just to see if the patient, when they left the cardiac after some period, so if the technology can help a little bit. So the main result from this systematic review again was that they found a small effect on subjectively measured physical activity and no effect when they measured objective measure physical activity, neither physical fitness, neither quality of life. So again, we are talking about, I mean, after completion of the cardiac rehab. But they also found some increase in terms of physical function. And again, so some concerns in terms of risk of bias. Here is just pointing out, I mean, some of those that was in yellow. So the size effect we can find. So it's a light, it's a it's a small to moderate size effect if we look at in terms of physical activity. It's a standard mean deviation of 0.37. But in terms of physical function, the median will increase in 8.47 in terms of the score. And again, so the certainty of the evidence for this information is very low, and for this information is low. Um, that's another very interesting article that I found on the recent literature. This is more related to what they call telehealth, cardiac rehab, and they also assess as other articles the effects on cardiorespiratory fitness measured by peak VO2, measured by 6-minute walk test, and also moderate to vigorous intensity physical activity. And yes, they confirm, I mean, that the telehealth improve all these outcomes. But I think the one of the most important findings from this article is that they tested what was the technological solution that would provide the best result for peak VO2 and for adherence. And they assessed this by using this methodology called surface under the cumulative ranking curve. And they found that the combination that has a greater impact on the peak VO2 is the combination of wearable devices and smartphones application, while smartphones application with instant communication tools was the greater tools or the greatest combination for the adherence. That's a very insightful publication. So in this other article, actually, I have two articles here, just talking about another important factor that we always think about when we talk about technology, which are the barriers and the facilitators of implementing e-health, and they all assess it on the literature. What was the most prevalent described barriers and facilitator? So this first article was wrote by our colleague Gizi. They describe technology, individual health considerations, um, uh, such as health or personal aspects, social factors like support from healthcare team and family, social support, environment like the facilities, and also the logistic factors like the time for displacement, for example, as the main barriers for implement e-health. These other article here above, they also present what they call some system level barriers and system level enablers, which is described in the screen. But I think that the most important part of the systematic review, which present kind of similar barriers and facilitators, but they present what they call the key recommendation. And as a cardiac rehab coordinator, I would say that's probably the most important part of this article, and then try to solve the problem. So try to implement some change in terms of leadership and implementation of the tools, and also related to the resource. So I think that's a very important aspect from the systematic review. Uh, and finally, so the other five articles related to, again, systematic review, another systematic review related to technology in cardiac rehab. So just the main conclusion from this article, we'll see again, so technology, rehabilitation, improving cardiovascular fitness again, cardiorespiratory fitness again here, another here, it's that's a new finding that's more related to risk factors, total cholesterol, total glucose, and blood pressure. Also here, again, confirming the effects on cardiorespiratory fitness, but also here they mention the accessibility and cost effectiveness of the technology. And also here, I mean, I would say they provide new insights, including the positive effects on left ventricular ejection fraction, and not confirming the effect on anxiety and depression. So I try to put all these 8 articles on this slide over here. So here we can have an overview. I mean, what the eight systematic review talk about in the last 12 months about the after cardiac he had what they call acute and midterm. I put all this information together here. And the following aspect. So as we see, so the most the largest effect we would say would be on adherence, followed by cardiorespiratory fitness, and the size of the change we will find, I mean, using the technology in terms of peak VO2 varies a lot across these articles that I presented, but it goes from 0.26 to 2.4. So that's a big change. I mean, that's a big difference among the articles. In terms of 6-minute walk test, so it's also varies from 11 to 45 meters. So which again, it's a large variation, but again, so it's a moderate effect. When we look at the long or the following long-term effects, so the most established, I would say, is the physical activity. So using technology post cardiac rehab program, it's more likely to be related to physical activity. So that's the summary of all the eight documents. So what is next? So I really like this review that talk a little bit about the future of technology, and especially talking about the virtual reality usage, which is something that can be very nice, very unique for cardiac rehab. And the authors on this article, they discuss the possible innovative ways where virtual reality can be integrated to the cardiovascular rehabilitation area, um, enhancing both precision of the procedures and training professionals and patients how to perform the exercise. So it might be something important. And of course, talking about what's going to be next, I cannot forget to talk about this. It actually was the only article published in the last 12 months regarding artificial intelligence. And it's actually just and it's not a meta-analysis, so they did a systematic review, but they don't present any kind of meta-analysis because it was not possible to compare all the eight articles that were included in this study. But they conclude that, I mean, the artificial intelligence would be, it's important to early detect cardiac events and also allowing home-based monitoring and also improve clinicians to decision making. So that's the most important points that came from this systematic review without meta-analysis. I would also add as some possibilities using artificial intelligence as a way to provide more personalized rehabilitation plans, to do some predictive analytics as they did right here. Uh, in the future, using the video capabilities, so possibly doing some virtual coaching and support for cardiac rehab. Again, decision support systems and enhance patient education. What we know that it's something very important. Uh, Now I'm into the end. I will just present some insights and some of the results from our group, and I hope you like it, and I hope we can discuss later after this presentation. So the first, okay, I just stopped at the audio. I don't know if you, yeah, if you hear the audio over there. But that's the first. It was the first initiative we did, and we start developing this platform in 2021. That what we call eHeart. So the eHeart was basically developed after the pandemic period, trying to be a solution to get something for cardiac rehabilitation patients that were not allowed to come to the cardiac rehabilitation settings or were afraid to come. So we developed this app, which was basically based on a very simple assessment, a very simple evaluation, which the professional would perform with very simple devices. And after that, so the patient were classified in terms of cardiac balance, flexibility, and strength, one out of one, in 1 to 4. And according to this classification, which was performed by a health professional, so the patient would receive a specific 36 session program, basically based on YouTube. But in fact, the patient doesn't go to the YouTube to search anything. So actually, they will receive daily or each 1 or 2 days a new complete program considering all initial assessment. And as you can see here, just of course that you can read it, but it's just to have an idea. I mean, how many exercise we have filmed and record, and then we allow the patients to see. I mean, these videos according to that classification, which means they just go to a complete session. But if I do an assessment for me or the patient, so I'm 100% sure that the exercise session provided for two different patients will be completely different. So that's something uh, that was one of the main objectives of this research, was to provide a personalized sessions. The exercise again was selected by curators before, and the patient had the possibility to keep using and to reassess. I mean, whenever they want, and as soon as they change, I mean, those parameters that I provided you before, so the platform will automatically change the progression of the exercise. So this is how they receive those videos in this screen. Uh, Here I'm just sharing some initial results from this study, which I had the privilege of having Dr. Reed participating on this. So it's now under review. So we did a first study regarding the usability. So we assessed 21 professionals who use the platform, and they provide some scores related to the usability, the information quality, and also the interface. And this number goes from 1 to 5, which the lower is the number, the best is the result. So we got pretty good numbers. I mean, for all the components that's established tool, how to assess. And also, we did a professional engagement and position questionnaire. And we also had, I mean, I would say pretty much for this, and this question, almost 90% of the patient, oh, sorry, the professional, I mean, providing good scores related to the application with the patient, assessment criteria, in-app recommendation. They only question a little bit more about how the prescription criteria would be effective. So they might have, I mean, a different opinion on how they would prescribe according to the assessment we provide, which is completely understandable. The second point, or the second publication related, was initial publication. We did it with a group of 9 patients, just assessing pre and post results, and we get some statistical difference even with this low number of patients in terms of quality of life, steps performance on a step test, and also strength on knee. So that's a very promising. Now our next step, I mean, when we get a new funding, it's going to be using this and applying in a large setting, and we might be try to compare this with a conventional intervention. The second technology we are now developing, that's what we call now eHeart EX. The EX come from exercise, so we are not very I'm gonna say we don't have great ideas in terms of name this kind of thing. So we take this from other professionals to try to help us. But I'm really happy and excited with this new technology that's being developed right now. It's from another grant, and basically, so this technology it came up. I mean, from from a lot of recent concepts and very well established backgrounds in terms of cardiac rehab, and we didn't find, it's this background available on the current technology available. And let's talk a little bit about this concept quickly. So we all understand that being active is far superior to leading a sedentary style of life. That's really correct. However, as a health professional who prescribe exercise as a treatment, we always try to recognize that higher is the cardiorespiratory fitness, the better are the clinical outcomes. And it includes improvements in terms of mortality, as we can see on this study that was published by Coquinos, and more recently, reduction in terms of hospitalization, according to this other very important publication on the European Journal of Preventive Cardiology. This other publication again also confirmed the very the great importance of increasing peak VO2 to the mortality again on this publication. So the insights from this study drives our approach to design and implementing exercise intervention that are not only effective, but also are tailored to improve cardiorespiratory fitness and consequently overall health outcomes. So, but yes, I mean, an exercise scientist or enthusiastic, I would say, the million-dollar question really always is, what is the best exercise prescription to achieve the most favorable clinical results in cardiac rehab settings? So yes, we know that is a very difficult question, and identify the optimal time, type, and intensity of exercise that can maximize the benefit without compromising safety requires a deep understanding of each patient's unique health profile and their specific cardiac condition. So I would say that's probably one of the first study that start to change our mind related to that, because if we go to the guidelines, which normally a professional goes to look at and be guided, I mean, how to prescribe exercise. So on this study, Dr. Dominic Hansing, which is a friend from Belgium, so he published this article and make a conclusion that the guidelines uh, they were inconsistent according to approximately 100 patients that were assessed using the ventilatory threshold, using the cardiopulmonary exercise test. And they, for the first time, probably uh, ask or suggest that the guidelines, the recommendation should be uh, changed or should be adjusted. Uh, on the same line, in 2023, we also did a comparison, and we also found that if we go to the all three main documents in terms of cardiac rehabilitation intensity recommendation, we see a huge difference between, for example, the Brazilian, European, and American recommendations to achieve moderate or high or very high intensity. And similar to what Professor Dominic did, so we took in this case 1,500 patients actually, and pull out the patients just to see. And all those patients had access to ventilatory threshold to the cardiopulmonary exercise test, and we saw that when we pull out all this patient, we see that the median and the distribution of the data was not, I mean, in where where they supposed to be, which would be in the moderate intensity. We see more figure on the in the low than in the moderate, as we can see. And this happens when we compare Brazilian guidelines, when we compare European guidelines, when we compare American, and also when we use it, different parameters, as we can see here. This figures in the middle, they're comparing percentage of heart rate peak. The figures here on my right side, they're comparing the percentage of heart rate reserve, and here on the left, the percentage of peak VO2. So they present different patterns, but we don't find, result that we consider satisfactory or very promising in terms of using none of those recommendations. And we came up, I mean, with the Brazilian data bank, with what we call heart rate or heart rate reserve adjusted numbers, which would be 39 and 78 in this case. So, which is kind of different from the recommended. Um, Another important article that I think it's important to mention is this one, which probably was one of the first studies that provided with a small sample size that volunteers that perform an exercise training based on ventilatory threshold, uh, they they had a greater results or better results compared to those using heart rate reserve. And more recent, so it's a huge systematic review that it was just came out last year. They compare the difference between using the ventilatory threshold to using what they call traditional methods. And as we can see here, so the mean, which is in the green, the mean on this group, it's around 4.1. That's the mean change compared to 1.8, which is a big change. I mean, it's a big difference. I mean, when we compare traditional and ventilatory basin. But again, we understand that I mean that is not applicable, or it's probably very difficult worldwide, especially in countries like Brazil, to have access to cardiopulmonary exercise test. So the most recent, so we start that's not the first article in the literature, but that's the article from our group. So we start thinking about try to develop uh, equations to predict heart rate at the ventilatory threshold, the first and the second. And the results confirm that appropriate equations to determine heart rate related to ventilatory threshold, they present higher R square and lower dispersion compared to all other methods of prescription. So in this case, if we don't have it, so on this first study, this first study, we included almost 1,000 patients from Brazil. Um, so we were able to provide an equation, uh, but I mean, it was necessary to get this information to at least have a conventional exercise test. On the second study, so more recently, we developed another study, which now was developed using a European data bank with almost 1,000 patients again, and we found this other slightly different uh, equations, as we can see here, also to predict ventilatory threshold one and two. And in this case, so we were able to prescribe or to get the ventilatory threshold based heart rate according to heart rate peak instead of using, as we can see here, for example, the MET value from the ergometric test. Again, so the R square was better than any other method compared on this study. And but if we go to the what we call traditional methods, including the heart rate reserve, so the heart rate reserve, uh, and here we can see here in this graphic, for example, uh, uh, the better the near the line is from the zero, it recognized as a method with a small variation. So which means that the equation proposed and the heart rate reserve, if we use the range adjusted, so remember, not the guidelines recommended, but the numbers that came out from the data bank. So they provide a pretty similar MAPE, pretty similar variation specifically in terms of VT2, but I mean, a little bit better if we go to the equation in terms of VT1. So that's the equation for based on European. And we did a validation on using a Brazilian, another Brazilian data bank, just to have, I mean, an idea. We understand that, I mean, people are different worldwide in terms of cardiorespiratory fitness, in terms of um, biotype, and that's why we consider important to test and retest in different populations. So with this in mind, so we develop or start to develop this tool, which is in the very beginning right now, but I'm just showing for the first time. I mean, some of the screen of this. I'm really sorry. It's only in Portuguese right now, but it's gonna be, I mean, in four language. That's the one of the main difference from this platform right now. So we already bought the company to develop this in four language. So it's gonna be available in Portuguese, Spanish, Dutch, and English. Um, and the interface, as you can see, it's very user friendly. So focusing on the easy of the use and use fewer clicks, which we think it's very important for the patient. So here we're gonna see, I mean, the initial part of each step or each phase of the exercise. Here, for example, is the beginning of the cardio activity, and here is gonna be the main screen. This color here on the background will change accordingly to the professional prescription, and this number will be changing, will change, I mean, accordingly to the prescription, and the prescription will consider all the recent background that I just presented, and just some of those rationales before. Here's just the RPA scale, and here's the screen after using the app. I mean, just showing some uh, daily or some messages to try to engage, I mean, patient involving in activity. And another thing is that, I mean, another important thing about this technology is that the same technology will also allow different patients using different wearables using the same platform, so they will not be attached to just one single brand, which is important. And also, they will allow the same platform to be used as a way to perform, for example, an exercise by themselves in home, for example, as a way to monitorize intensity of exercise if they are out of the cardiac rehab. But if they want to come to a cardiac rehab setting, so we're gonna have a option to monitor as many patients as we want and have several patients controlled by one screen. I mean, and then the professional can have an idea from a lot of patients at the same time. So here's just a initial. We think that, I mean, in addition to the very traditional zone of exercise, which is very common for all exercise specialists, we also created another screen like that, which will create what, I mean, based on the colors. I mean, what will be the zone, the appropriate zone, in where the patient are. And one big change, and something that bothers me, I mean, before, is that if you go to any other technology, for example, using Polar, using Garmin, of course, that if you are doing, for example, a warming up or you are doing a cooling down, of course, that if you are warming up or cooling down, you're not supposed to be on the moderate intensity, because I mean, you are doing cooling down. You are not doing a cardio exercise. So, and when the patient finish the exercise using this regular devices, so normally the device will provide for the patient, for example, that they expand 60% of the exercise on the appropriate heart rate zone. So this number for me doesn't sounds very good, because sometimes you want them to stay with a low heart rate during the warming up. So that's the target zone at that type of exercise. Or you might say during the strength thing, I would allow the patient to vary much more during the strength thing than running the cardio, and that's the target zone. So in this case, so with the second screen, as we show here, our idea is that the patient will try to pursue 100% of the time doing exercise having a target zone achieved, which means, I mean, target zone for each specific phase. That's probably one of the other important changes from this solution. So finishing, I'm just putting some take-home message over here. So, which I think it's important to keep developing health technology with an integrative approach. It's not a substitution; it's an integrative approach. Incorporate demographic indices into algorithms to improve precision and individualization for all these technologies. Train healthcare professionals to health and also patients to enhance technology literacy and develop technology with a low learning curve. That's a term that I've learning with the colleagues from the IT area, and also utilize technology to increase patient adherence and improve cardiac rehabilitation efficiency. So, as we saw, I mean, in the last 12 months, so it's something very feasible, and I would say with a good foundation on the scientific literature. So I hope this presentation has provided you valuable insights into the integration of advanced technology in healthcare, specifically in cardiovascular rehabilitation. And I want to thank you again. Thank you again for the invitation, and I'm more than happy to address any question you might have. Thank you so much.
Wonderful. Can you hear me?
Yes, I can hear you.
Thank you so much for your presentation, Dr. Cipriano. And again, thank you for sharing. We actually had the opportunity to host you here for a few days last year. And then we met again up at ESC Preventive Cardiology. I think the work that you're doing in the technology space is especially innovative. And in the Canadian context, we're a very large country, and many of our individuals live in rural areas. So the consideration of innovative technologies in terms of reaching more patients, not only in the short term, but also the long term, I think is a really critical aspect for not only Canadian programs, but for those in other countries that want to serve much larger populations. I do have many questions for you, but I'm going to start off with some questions from the audience first, because I can always poke you a bit later. So first up is this microphone. We're seeing a myriad of remote monitoring devices and tools entering the market. If, as an institution, we want to be early adopters, what should we be looking for?
That's a nice question. Yeah. So I think I would say, as I presented on my last slide, uh, I would say using a technology that requires uh, a learning curve, a small learning curve, would be the most appropriate to decide. Uh, Again, if we go to a very robust technology, but I mean something that patients or professionals cannot usually use this, I mean, routinely, so it doesn't make, I mean, any sense for the adoption. So I would say using technology that is easy to use, that is it's gonna be my first choice in terms of selecting a technology.
Thank you. And I'll just remind those in the room, if you have questions, just pop over here to the mic and I will certainly hand it off for you. Another question from the attendees is, what is the root cause of the problem that technology is solving for? Is it cost, accessibility, location? What do you think is the primary problem it's addressing or hopes to address?
Okay. Uh, Yes, I think I've learned a lot. I mean, from the two publications that I mentioned, and they presented some of those barriers and facilitators, uh, and they mention as barriers, as I already said. I mean, the difficulties of using the technology and not having the support from the health professional as one of the main factors of for not using. So they they try to understand, so they look for support. But if they don't have, I mean, the support available, so they might simply decided to not use. So this is one of the important barriers, I would think. Uh, Another thing, it's probably related to cost, of course, um, since it's something that it's starting to being created, especially for cardiac rehab settings. As I mentioned before, so most of the technology we use in our cardiac rehab settings, I would say, were not developed for cardiac rehab patients. And if we go, for example, if we compare uh, uh, I'll talk about a brand here, not a problem, no commercial conflicts. But if we compare, for example, the costs for the Polar monitor compared to another system to monitor in patients, which was developed for cardiac rehab, we know that the difference in terms of value are huge. So that's another important problem. So but again, so as much as the cardiac rehab centers start using, so what we expect at that is that the price would probably decrease because I mean we're kind of sharing the costs with uh, different centers that and that is something that I we also um felt, I mean, in our system. So the e-heart, so we developed, so we spend a lot of money, and this is a different, little bit different because it was a money provided by an agency. But of course now, I mean, the system is ready. But if a cardiac rehab center wants to start using the system, so if I don't charge, I mean, anything, I mean, to provide the solution, so it has a cost included to make the system available, to have a lot of patient assessing, to receive message. So there's a lot of costs involved, I mean, on this kind of platform. So I would say the learning curve and also the cost would be some of the barriers to of using more routinely, I mean, this kind of technologies.
Thanks for getting to the cost. That was going to be one of my questions. So it's helpful to hear some of the specifics of how you are addressing the ongoing costs of using these programs. We have a comment and a question from Dr. Rob Leland, who is our CEO and president. He has a thank you and great rounds and agree with the need to enable care with increased use of technologies. How do you enable these advantages transition to vulnerable communities that don't have access to these technologies?
Thank you very much for the question. And in our case, so it was cheaper as a researcher to look for a funding and develop this solution. So we tried to develop. Of course, that we didn't think about developing a solution that was only for our patient. We tried to develop something that would be used in by different professional, different cardiac rehab centers, and so that's the thing. I mean, we use them and to have access. And now, since it's ready, and I would say it was something that was provided by agency, was not something that was private. I mean, it was paid by someone. So the good advantage, it's now in the future. So we are able to provide this solution for other cardiac rehab centers um, by a low cost again. So we don't want to have a profit with this technology. We just want to have the costs for having the service, I mean, running. So I hope, I mean, in terms of helping other communities, as mentioned in the question. So this solution can help, I mean, try to spread the cardiac rehab at least with a minimum quality and a little bit of personalization, and without requiring the professional, the health professional, to be with each patient, I mean, each session. So that's what we call something that would be scalable for larger use.
Hello, Dr. Cipriano, Matheus Hausen talking here, postdoc fellow from the Exercise Physiology and Cardiovascular Health Lab. I have two quick questions. Feel free to expand. First of all, congratulations on the great presentation. Proud to see robust Brazilian studies in the presentation. My first question is about how to address limitations in digital literacy of patients, especially from the ongoing generations, because we know next generation will be easier to adhere to technology, but the current generations not so much. And my second question is about when you presented your studies about the equations to estimate the thresholds, if you consider including, or maybe for next studies to include uh, more variables to individualize, because we still rely on general models to estimate the thresholds. If you still consider including the model basic information like age, weight, level of physical activity. So that's my two good questions.
Okay. Thank you so much for seeing you again, Mateus. It's a what's one of the guys responsible for receiving me when I went uh, to Ottawa. So thank you so much, and I hope we can see you in the near future. Uh, so for the first question related to the literacy, so yes, it's something that we have to concern always. Uh, but was interesting. I mean, discussing and having a lot of discussion. We have a kind of a weekly discussion with the IT guys who are developing the technology, and they also present me, and I've learned a lot about this. And one of the good sides, if we can say that, I mean, of the COVID, is that this population were more focused on their phones than they were in the past. So, which means they were kind of forced to use the technology, and most of the patients, I mean, start using at least the basic technology. So with this in mind, so yes, we are completely sure that in the last 3 years, so patient increase a little bit the literacy about using their at least their phones. And the other side is, I mean, how the solution is developed. So it's very interesting because when we develop this, so we are always counting the number of the screens, how easy it is to set up, and how is require how I mean what are the tasks required to use. Just to give you an example, for example, on the first platform. So we were able to use, for example, a wearable device to catch biological information. But at that time, so the company who was developing the first, they were not able to collect the data directly from the wearable device without requiring the patient to install the app, to 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 attach the app to the device, and then to allow on the Bluetooth section getting information from this. So they have like maybe 20 clicks before start using. So, and just because of that, we decided to not include this because I mean we assume that would be a very important problem, I mean, in terms of adherence. So again, just answering your question, I think it's the way we develop the solution. It has to be thinking about, I mean, what is designed for. So again, that's what we're trying to do in our solution, and I'm sure, I mean, all other technology which is developed for this population has to consider this low literacy and and but yes, I think it's possible for most of the patients, not for 100%, of course, but for most of the patient, if you take care, I mean, on this click things, I mean, something that is very easy. So the new platform, which use a lot of devices, so the patient doesn't have to click anything. After they receive a message, they just confirm their data, and they just press a button. There's just one button on the screen. After they press this button, they automatically pop up on a screen saying searching for devices. So whenever the device they have near, so they will try to attach it automatically without asking the patient to provide codes or this kind of things. So that's simple, but but it makes a lot of change, a lot of difference, I mean, in terms of usage. So I think I answered the first question. uh, the second question, which was related to the models, um, Yes, so actually, when we tested the predicted variables, we have included all the variables. But again, so the variables related to exercise were the variables that stay on the model when we compare the quality. And I know that it's and it's something that we also put on the second technology, the eHeart-X, which is for us, for our group. So we nowadays say that we don't consider using or doing any kind of prescription without doing at least any form of exercise test. So it doesn't have to be a CPAT, it doesn't have to be uh, or I would say it would be ideally perform the CPAT or the regular exercise test. But if you don't have it, so we have to think. I mean, it's our thinking right now that we have to at least do any kind of exercise, even a step test or a 6-minute walk test. Because I mean, there's an error, for example, to estimate the maximum heart rate from the 6-minute walk test or even from the 6 minute step test. But the error, the error that comes from the prediction equations without using any form of exercise are much higher than compared to the other forms that use any form of exercise. So we also tested this. So and saw that the MAPE, the mean error when we compare CPAT exercise, the regular exercise test, 6-minute walk test, and only the predictions, the difference when we include only predictions are huge. So the recommendation, and that's gonna be the one of the core standards from this platform is that, okay, as a health professional, you should perform at least one exercise test. And okay, if you don't have access to exercise test, the regular exercise test, you should perform at least a 6-minute walk test. And then using the amount of change in terms of heart rate or the distant cover in a 6-minute walk test, this variable can be translated to a maximum heart rate, and then so we can use our formula to try to surrogate the heart rate at the ventilatory threshold with with a precision which is far much better than not using any form of exercise. Make sense? So that's why I mean we go to this way of try to incentive professionals to at least do any form of exercise as an assessment. Make sense?
Sure, thank you very much. Congratulations.
Thank you. Thank you.
Thank you so much. I think we could be picking your brain all afternoon with the questions coming through, but we will have to let our audience go, both those online and in person. I want to thank you so much for your time this afternoon, presenting the projects that you have that are completed and certainly those that are ongoing. I see a lot of opportunities here for multinational, multi-site investigations between the work that you're doing and our center. So I look forward to continuing our conversations. And again, thank you on behalf of the University of Ottawa Heart Institute for presenting at our cardiac rehabilitation rounds.
No. Thank you very much. That's my pleasure again. So I hope we can continue collaborating, and I'll be more than happy to be whenever you think is necessary. Thank you again.
Thank you.